Welcome back to the IJGC Conversations, the October's editor choice. We are diving into some recent publications that caught our eyes. I'm Tommaso from Filippo del Ponte Hospital, University of Insubria, Italy.
And I'm Carlotta Sabini from Ospedale San Raffaele, Milano, Italy. Always great to dive into the latest research. Hey Tommaso, we've got three really impactful papers today, focusing on critical areas in gynecologic oncology, managing rare tumors, surgical safety innovation, and infection prophylaxis.
Absolutely. As junior investigators, staying on top of these complex, often conflicting findings is essential. Let's dive right into our first paper, which addresses a rare and highly aggressive tumor subtype.
Yeah, our first discussion piece is titled Endometrial Carcinosarcoma Without Myoinvasion. This was authored by Giuseppe Cucinella and colleagues, whose affiliation is the Mayo Clinic Department of Obstetric and Gynecology, Rochester, Minnesota, USA.
This paper focuses on a very specific and rare subset of uterine carcinosarcoma, those without myoinvasion, limited either to the endometrial lining, a polyp, or with no residual disease found during hysterectomy. Carlotta, remind us why this specific group is so challenging to manage.
The management of FIGO 2009 stage 1A carcinosarcoma without myoinvasion remains uncertain because there is limited evidence and previous outcomes were largely unknown. Traditional guidelines like the 2021 ESCRO-ESGO-ESP guidelines classify this scenario as intermediate risk, generally not recommending adjuvant therapy or considering it case by case.
So, what did this large multi-institutional study of 97 patients actually reveal about their outcomes?
The core finding is concerning. Patients with carcinosarcoma without myoinvasion have a poor prognosis. The study observed a relatively high recurrence risk. Specifically, the overall recurrence rate was 29.9%.
That recurrence rate is high for what is considered an early stage non-myoinvasive disease. And where did these recurrences typically occur?
The majority of relapses showed a distant pattern of spread. Most recurrences were peritoneal, followed by lymphatic and hematogenous. Interestingly, even in the small subgroup where the tumor had no residual disease in the hysterectomy specimen, all four recurrences were distant.
That really highlights the aggressive nature of this tumor regardless of a minimal initial involvement. Given that distant spread is common, what was the takeaway regarding adjuvant chemotherapy?
That's the critical question. When comparing patients who received adjuvant chemotherapy versus those who did not, the differences in oncological outcome did not meet statistical significance. The 5-year recurrence-free survival was 77.6% in the chemotherapy group versus 51.7% in the no chemotherapy group. Similarly, overall survival differences were not statistically significant.
But the authors do offer a caveat about the lack of statistical significance, right?
Correct. They suggested that the small sample size and retrospective nature of the study may have limited their ability to detect a true difference. Ultimately, the study concludes that given this poor outcome and high recurrence rates, consideration of adjuvant therapy is warranted, potentially reclassifying this patient as high risk, although the high-level data supporting this recommendation is still lacking.
Moving on to a topic focused on surgical innovation, Carlotta, can you introduce the second paper?
Certainly. The second paper is a review focused on surgical adjuncts in green fluorescence angiography for bowel anastomosis assessment in ovarian cancer surgery. The first author is Stephanie J. Gill from the University of Toronto Department of Gynecologic Oncology, Toronto, Ontario, Canada. This review addresses a major concern in cytoreductive surgery for advanced ovarian cancer, anastomotic leaks following bowel resection. Why are these leaks so devastating?
Anastomotic leaks can lead to pelvic abscesses, peritonitis, and fistulas. They are associated with substantial morbidity and can lead to mortality rates up to 20% due to infection sequelae. Furthermore, they contribute to prolonged hospitalization and can delay the start of adjuvant therapy, negatively impacting overall prognosis.
Right. And traditionally, surgeons rely on subjective methods like visual inspection and palpation to assess tissue perfusion. ICG-FA, or indocyanine green fluorescence angiography, offers a promising objective alternative. How does the technique actually work?
ICG is an inert water-soluble fluorescent dye. It's administered intravenously, binds to plasma proteins, and distributes through the bloodstream within 2 to 3 minutes. When excited by near-infrared light, it fluoresces, allowing surgeons to visualize tissue vascularity in real time. Well-perfused segments show rapid, uniform fluorescence, typically within about 60 seconds, while poorly perfused areas show delayed or no fluorescence.
We know ICG-FA is widely adopted in colorectal surgery, but the evidence is controversial, isn't it?
It is. While some randomized controlled trials, like the FLEC trial and the Essential trial, demonstrated that ICG-FA significantly reduced anastomotic leak rates in specific low or minimal invasive rectal cancer surgeries, other large trials, such as a Pillar 3 or AVOID, did not find a statistically significant reduction in leak rates compared to conventional methods.
That variability is interesting. Does the review shed light on its utility specifically in gynecologic oncology?
Yes, the incidence of anastomotic leaks in gynecologic oncology, particularly in advanced ovarian cancer cytoreduction, is notably lower than in colorectal literature, often reported below 7%. This is partially attributed to a wider, more compliant female pelvis, which allows for tension-free anastomosis, and the lack of common risk factors like neoadjuvant radiotherapy, which is frequent in rectal cancer.
Even with lower baseline rates, the consequences are severe. Did ICGFA impact surgical decision making in the smaller gynecologic oncology studies?
It did. A retrospective study found that ICG-FA detected hypoperfusion in 3% of anastomosis, leading to intraoperative modification like re-resection or creation of a protective diverting loop ileostomy. Another study noted that ICG-FA use was associated with significantly lower rates of diverting ostomies, postoperative abscesses, reoperation, and hospital readmissions. The authors highlight that while ICGFA is safe and feasible, we are still waiting on definitive high-level evidence from the ongoing Area 2 multicenter randomized control trial, with results expected in late 2027. Now let's switch gears to infection prevention, which is fundamental to postoperative recovery. Carlotta, please introduce our final paper.
Our third article is titled Addition of Metronidazole to Standard of Care Perioperative Prophylaxis at the Time of Hysterectomy for Gynecologic Malignancy. The author is Megan Gorman and the affiliation is Northwell Health Zuckerberg School of Medicine at Hofstra, Northwell, Long Island, Jewish Medical Center, Department of Obstetric and Gynecology, Division of Gynecologic Oncology, New Hyde Park, New York, USA. This study tackles surgical site infection or SSIs following hysterectomy for cancer. What is the current standard prophylaxis they were comparing against?
The standard of care prophylaxis involves using cefazolin or a second generation cephalosporin to cover endogenous pathogens of the skin and vagina. However, these cephalosporins have limited activity against anaerobies. The logic behind adding metronidazole is that it provides effective coverage against anaerobic bacteria, specifically targeting species like Bacteroides fragilis and Gardnerella vaginalis, which are implicated in post-hysterectomy infections.
And this study specifically look at the oncologic population, which is important because surgery for gynecologic malignancy often involve extensive procedure like bowel resection, increasing the risk of infection compared to benign cases. What was the overall finding regarding the SSI rates?
The retrospective cohort included 1,055 patients who underwent hysterectomy for malignancy. The overall rate of any surgical infection was 3.2%, which is comparable to national estimates. When they looked purely at the raw rates, the SSI rate was 4.3% among patients receiving standard of care antibiotics alone versus 2.1% when metronidazole was added. This difference shows an independent association between antibiotic regimen and SSI rate.
That initial 50% reduction sounds clinically significant, but what happened when they adjust for known confounders?
When they ran a mixed effects binary logistic regression, adjusting for smoking status, diabetes, and open incision, the association disappeared. The addiction of metronidazole was not statistically significantly associated with a reduced risk of SSI.
So, while the odds were cut roughly in half, we can definitely say that metronidazole addition caused the reduction based on this adjust analysis. Which factor did remain independently associated with infection risk?
Diabetes and active smoking status were statistically significant predictors. Patients with diabetes had 2.9 times the odds of experiencing an infection compared to non-diabetics, and active smokers had 4.1 times the odds compared to non-active smokers.
That confirmed that optimizing patient risk factor remained critical, regardless of the antibiotic cocktail. Did the study address its own limitations?
Yes, they were quite transparent. They noted that the lack of statistical significance for metronidazole may be due to the relatively small sample size and the low incidence of infection, suggesting that the study may have been underpowered to detect this specific difference. They also acknowledged that the protocol change of their institutions simultaneously included a shift in vaginal prep from iodine to chlorhexidine, which could have confounded the results. They ultimately concluded that future research with a larger sample size is necessary to firmly establish the optimal infection prophylaxis regimen for these patients. Well, that was a packed session. We covered the aggressive nature of early stage carcinosarcoma, the promising but still controversial role of ICG-FA in optimizing bowel anastomosis outcomes, and the complexity of confirming the benefit of metronidazole for SSI prophylaxis in oncologic hysterectomy.
Definitely fundamental reading for anyone in the field. Thanks, Tommaso, and thanks to our listener for joining us for the October Editor's Choice.
A huge thank you to Carlotta, such for an insightful conversation, and thank you to all our listeners for tuning in.
We encourage you to seek out these excellent articles for more in-depth information. You can find them in the International Journal of Gynecological Cancer. Thanks for joining us, and we'll catch you next time. We'll be back soon with more updates from IJGC.